Yes.
Hello, everyone. Welcome to our CMS training. I'm going to actually just switch to sharing my slides here. If I can figure out how to do that. So today we're going to talk about the CMS data that's available via the N3C PPRL for patient privacy preserving record linkage. Today we have Tom Richards and Stephanie Hong, both from Johns Hopkins, and then I'll be following up talking about PPRL a little bit. My name is Sean and I'm from CU Anschutz. Tom, do you want to go ahead and get rolling?
Yeah, that sounds good, Sean. Can I share my screen with the slides instead? Do you mind? Okay, thanks. All right, let me give me a minute here. Okay, so hopefully you can see them. I'm gonna switch to
yeah, you can see
a slideshow, so I won't be able to see the chat when I do this. So just let me know if there's a chat that I need to talk about. So hi everyone, I'm Tom Richards. I'm Sean mentioned I'm a researcher at Johns Hopkins University. I've worked with claims data in general, but specifically Medicare and some Medicaid for a long time, both on the research side of things and then also a while ago when I first started out on the billing side of things. So I've gotten to see the data both sort of going out to CMS and coming back from CMS. I don't want to spend a lot of time. This is the third time we've done this, and some people may have heard it 3 times, but a couple of points I want to make here is that CMS is big. They administer multiple programs. We're going to talk about Medicare. The Medicaid data is coming into N3C as well. They're both administered by CMS. We're talking about claims data. CMS has they go back a long way, and they have data that goes back a long way. I think we're going back to like 2017 maybe with the data. And then there are 2 types of Medicare. There's what's called fee-for-service, and that's more like regular insurance for those, most of us probably have, traditional insurance, or it's, it's like Blue Cross Blue Shield or United, something like that, where a patient can go wherever they want. They'll pay some of the costs. The insurance company will pay some of the cost that's based on deductibles that a patient may have or a percentage. And there are rates that are negotiated with the provider. So, you see that when you go to the doctor, they submit a certain amount, but there's only a certain amount that they're allowed to be reimbursed for based on agreements that they have. So there's a fee-for-service Medicare. There's also what's sometimes called new Medicare, which is also called Medicare Advantage. That's more like an HMO, where a person can goes to a doctor within a group of providers who agree to participate in this program. And so it's more managed. And because it's more managed, there is a greater ability to control costs and utilization. And because of that, over the past 10 years, but even more recently, there's been a huge push to move Medicare people off of fee-for-service and onto Medicare Advantage. What we have is circled in red. We have the Medicare fee-for-service. These numbers are from a year ago, or a little over a year ago. It may be that Medicare Advantage eclipses fee-for-service now. This year, I'm not sure, but we're certainly moving in that direction. There are different types of services that are covered by Medicare, and they call them parts A, B, and C, and A, B, C, and D. Part A for basically is like inpatient. Somebody goes to the hospital, they're there overnight or a couple of days. Medicare covers that and pays that under what they call Part A. When someone goes to their doctor in an ambulatory setting, they're just going for an annual health check or an acute illness, a sore throat or something like that, certainly, to be tested for COVID. That's going to be covered under what's called Medicare Part B. Part C is the Medicare Advantage stuff, and we don't have that. And then Part D are prescription drugs. So that's kind of how Medicare sets their data up. The good news is that I'm mentioning this because you may hear about it and see it referred to in parts, but the transformation that's been done to the data puts it all into OMOP, kind of all mixed together and cleaned up in a nice way. One other thing I didn't mention, that Medicare, you tend to think of it as healthcare for the elderly. So it's 65 and over. When you turn 65 in the United States, you're eligible for Medicare. But there is not an insignificant number of people, 9 million out of that 60, I think it was 60 some million, whatever, so close to 60 million. About 9 million people are enrolled in Medicare and eligible for Medicare because they have a disability or renal disease. So end-stage renal disease and certain disabilities, people can enroll in Medicare when they're under 65. So you'll see that in the data. What we have are claims data, and claims are different than EHR. So a claim is basically a transaction, a billing transaction, and it's an audit. Claims are an audit trail of the billing transaction. So someone goes to the doctor submits a bill to Medicare. Medicare might reject it and send it back for some reason. Then the doctor makes an adjustment to it and sends it in again. So there can be 3 or more transactions just for one service. The good news is, and that process of trying to clean up the bill is called adjudication. The good news is that what we have in N3C are fully adjudicated. Sometimes they're called final action claims. So it's sort of the final claim, and we don't have to be worried about that adjudication process. That process takes time. So there's a latency between when somebody has a service and when the final bill is actually taken care of, final payments taken care of. That latency of about 3 months gets well over 90% of services fully adjudicated. And I think we're getting, the data is being updated every month, but it's going back like 2 or 3 months. So we have pretty complete data and fully adjudicated data. So it makes it a lot easier to work with. There are some big differences between claims and EHR. Claims, well, these are coming from Medicare. They come from an insurance company, and a person's services get submitted to their insurance no matter where they go. So if you're used to dealing with an EHR in one healthcare organization, you see what that patient had done there. You don't necessarily see what they had done anywhere else. The claims will tell you what they had done everywhere else, including all the sites that submit data to N3C and sites that don't submit data in N3C. So we're going to have everything. So that's a big advantage of claims. Claims also represent sort of what really happened. A patient had this procedure done, or they filled this prescription. So it's reality in a way. The EHR, in many cases, is intent, particularly with pharmacy. So there's a prescription written and it's recorded in the EHR, but you don't really know if or in a lot of cases, you don't really know if that patient filled that prescription or not. So sort of intent versus reality. So that's a benefit of claims. One of the disadvantages or advantages of EHR, disadvantage of claims, is that the claims, they're very good at what's important on a claim, which is what's important for billing, where the person went, who they saw, what the date was, what procedure they had done, and what diagnosis they had done. What the insurance company doesn't care about is they care that you had a lab test for maybe an A1C level, but they don't really care what the result was. They're going to pay that A1C test, a certain amount. So you're not going to get the level of the lab result. You will get that with the EHR. So that's a benefit to the EHR. A little sort of nuance to claims is that they sometimes get altered a little bit, but when they're getting submitted. So somebody comes in, they see the doctor, things get entered in the EHR. Ultimately, that stuff goes through a billing department, and the billing department will adjust things to submit them to the insurance companies for payment. And sometimes that's called upcoding, and you might see things added to the claim, or like a diagnosis might be slightly altered, or a procedure might be slightly altered to indicate that the procedure, had a technician involved in performing it, in addition to a physician involved in reading, determining, looking at the result, interpreting the result. So there's sometimes a little bit of expected differences between EHRs and claims. In OMOP, I mentioned everything, it's been adjudicated, everything has been loaded. If you're someone out there who's used to working with CMS claims, down here I've shown that all 7 types of the CMS claims have been loaded into OMOP. This is Part B, durable medical equipment, inpatient, which is Part A, hospital outpatient, skilled nursing facility, home health, and hospice. So all of those types have been loaded, transformed and loaded into the OMOP data structure. An additional piece that I just want to spend a minute on before I wind up this section is the beneficiary summary file. So claims data isn't just the billing record, but there's also a record of when the patient is eligible for that insurance. In Medicare, in CMS data, that's called the master beneficiary summary file, or that's what we have. And it tells you on a monthly basis, was the person eligible for Medicare, and what types of Medicare, and maybe why they were eligible. Are they, well, not maybe, it tells you why they were eligible. Did they age into it? They're 65 and over, or were they one of those other categories I mentioned, disabled or renal? Another thing it will tell you is what's called dually eligible. Those are people who are Medicare and Medicaid. They're important because what that tells you is that if you're just dealing with the Medicare data, you don't have everything because they're in both Medicare and Medicaid. So, you may not have the Medicaid part. The good news with N3C is that I know they're loading Medicaid data, and that'll be available sometime soon. So, the other thing that the beneficiary summary file will let you do is it lets you distinguish something you can't do in the EHR. It lets you distinguish between somebody who's not there, but they're eligible. So you look at the EHR, you have a patient record, but no utilization for the year. You don't really know anything about that patient because you don't know, did they go somewhere else for their services? Were they just healthy and they didn't come in? In claims, you can sometimes make that distinction because you see that somebody's eligible for all of 2022. Every month in 2022, they had Medicare, but there was no utilization. And you would know it if they went anywhere in the country, you would have it in the claims. So that, there's no utilization. So you might be able to make, a distinction between somebody like that. Maybe they're healthy, or you might lean to think that they're healthy versus somebody who wasn't eligible for every month, who you don't really know about. Like somebody in an EHR who just didn't have utilization. So that's one thing you can do. And the other big thing is if you know the number of months somebody's enrolled. So if somebody's enrolled for 6 months and they have 1 visit, and somebody's enrolled for 12 months and they have 2 visits, you can annualize things. So you probably wouldn't do it this simply, but you could say, okay, if somebody's enrolled for 6 months, then double their visits. And then you're comparing sort of apples to apples. Again, that's the simplistic. There are more sophisticated ways of annualization, but you can do that with claims data, and you can't really do that. So I'm going to wind up here just because I'll come back to this stuff later. But just one takeaway is that just remember what I said. If it's important for reimbursement, I mean, that's money It's important for the money. So the submitter's going to get it right, and CMS isn't going to pay it unless that stuff is accurate. So trust it. And in some cases you can trust it over the EHR if it's important for reimbursement. Here are a couple sites that have some helpful information regarding CMS data, and they'll be on the slide. So that's it. So Sean, I'm going to stop sharing, and then it'll be back to you.
All right, now we have Stephanie Hong up to talk about mapping to OMOP.
Hi, this is Stephanie Hong from Johns Hopkins. I work at Dr. Schutz's lab, where we harmonize all of N3C data. Today I'll be talking about CMS harmonization to OMOP. So we have a number of other PPRL linked data set within N3C, and CMS data is the most recent one. And there's also a N3C clinical data that is coming on board as well. So we have CMS. We currently just have Medicare, but Medicaid data is being processed right now, and it will be available sometime next year. We have social determinants of the health data, viral variant data, and mortality evidence data also linked through PPRL in N3C. Next slide, please. So in our harmonization pipeline, we took all of the CMS claims data from inpatient, outpatient, hospice, home health, durable medical equipment, skilled nursing, Part B and Part D claims data, and mapped them into OMOP, a person-centric OMOP's common data model. And here I'm showing all the different tables that exist in OMOP. Next slide, please. So when we harmonize the data, we do them in stages. We take all the person that exists in the claims data and create a person table. And then we look at all of the visits based on the claims information, and create the visits based on dates and various different care sites that it was referenced within the data. And then we take all of the codes that exist in the claims data, whether it's diagnosis, procedures, HCPCS or CPT codes, and we translate them into OMOP concept IDs. And when we do that, it lets us know where we should place that particular data in which domain, or in other words, which table within OMOP CDM. So that's the process we have taken. Next slide, please. Next. So when we looked at the claims data, some of the codes that exist in the source files were spread across, many different columns. So we took all of these wide format tables and made them into a single code and a code system, so that we could efficiently map the source codes into a OMOP concept IDs. And this is just a explanation of how we handle the code map service. Next slide, please. So when we map the visits, it's based on the dates of the claim, but also based on revenue center code. The visit can be associated with either inpatient, outpatient, home visit, emergency room, televisit, pharmacy, ambulance. There are some laboratory visits as well. And then we do make the distinction between whether person became inpatient from an outpatient setting and whether inpatient, a person got admitted to inpatient from emergency visit. So those visit types do get reflected in the data. Next slide, please. And just wanted to let you know that links to those visit mapping is documented in our N3C GitHub page. So when we do the translation of all the codes that exist in source data, there are two levels of mapping that takes place. And one is a value set mapping that is enumerated list of permissible values per data element that exists in the source data, like sex, race, ethnicity, where we have a distinct set of value that can be possible. And then there are hundreds of codes that could exist in the data. So we do that translation based on the terminology ID. And here is just the picture representation of the value set mapping. So we comb the data to make sure all the gender that are specified in the data, all the race that are specified in the data, and all the ethnicity value. Ethnicity value was overloaded with this on the same column where the race is presented. So for those rows of data where it's coded with ethnicity, race value is not well defined. So there are cases where we will know that it's either it's Hispanic or not Hispanic, but because of the fact that it was overloaded in the same column, the race value, it is possible that we have a zero map race values. And for the gender, it's just sex at birth and not really associated with a gender identity. And the race values are basically set to the 5 OM, I believe the OMC define race codes. Next slide, please. So here, all the code that exists in the source data were ICD-10-CM, ICD-10-PCS, PICS-PICS, CPT, CVX codes, as well as 11-digit NDC codes. And those are all mapped to the proper OMA concept IDs using the OMA vocabulary tables. These codes are considered non-standard code from OMA point of view, and they get all mapped to the associated SNOMED code concepts using the OMA relationship table. The observation period is based on the enrollment that exists in the data. It is possible for a person to have partial enrollment months for a given year. So that will be reflected in the data as well. Next slide, please. So based on whether the drug was administered versus prescribed, there's a difference of nuances, whether in terms of whether the person had actually received the drug or there were
Did we lose Stephanie? Stephanie, you back?
I'm back. Sorry, got
All right.
dropped for a second. So I was just saying there are some analysis consideration that you should take into account, and that is when the person was given a prescription to a drug versus when the person was administered to a drug, which exists in the EHR data. There's a different nuances in terms of drug type. So you can check the provenance of the drug, and if that is important to you, whether drug was actually given to the patient versus it was just prescribed, and we don't have confirmation of whether they took the prescription, but whether the person actually took the full dose of the drug that was given to them or not. If you want to have that nuance in terms of analysis, you can always check the provenance of the drug in the drug exposure domain. And the care site, which is the provider information within the Medicare, is basically where the care was provided as like a physical facility. And we didn't incorporate actual NPI information, but that will be coming in the future. So both currently, all the visits are mapped to a facility, but in the future, we will also have facility as well as the provider who have given care to the patient. And the payer plan period, as Tom mentioned, there's nuances to whether the person had multiple plan, was eligible to have both Medicaid or Medicare, and those information will be expanded to our enrollment data, and it'll be available as well. And the payer plan period data set will also be coming in the next build. Next slide, please. Okay, so back to Tom for some of the CMS challenges and analysis tips.
Okay, thanks. Yeah, I'm just sharing now. Okay, I'm going to switch to a slideshow again. Okay, so I just wanted to come back and point out a couple things about working with the claims and maybe the claims mixed in an EHR environment. So it's sort of general, maybe not totally specific to N3C, but some things to watch out for. The CMS data and N3C, particularly with things like provider ID mapping and maybe dates, and something I learned about fairly recently that I think you all call macro visits. Those are changing rapidly and frequently within N3C, I think, and with things being made better and easier, and some of these challenges maybe, being eliminated or at least diminished. So, but these are just some things to be careful of when working with claims and EHR data. So, one has to do with patient identifiers. So in this environment, we've got multiple sites that are submitting EHR data, and now CMS submitting claims data. and there can be different patient identifiers from all these different sites, and whether or not you can tell that an EHR patient is the same CMS patient between site A and B sort of depends on the agreements that have been put into place. So I have to admit, I don't totally understand it, and there are people on this call that understand it a lot better than me, and maybe they'll talk about it later, but something to be careful of is that, and I think you're already dealing with this to some extent, that patient X and patient Y are the same patient in the two different EHRs, but you may not know that. And now it even gets complicated further with CMS data. And it may not have been that big of a deal or big of an issue up to this point, because people tend to be, receive their care in one health system maybe, and you don't see, vast movements of a population from one EHR to another. But this population of CMS patients is maybe different than what's been in the EHR. I mean, like I said earlier, it's predominantly 65 and older. So you're talking about a lot of retirees, and, a lot of them may, or fair portion, significant portion of the population may spend, may change residence with seasons. So they may, winter in one place and summer in another, and they're going to get their health care from two different EHRs. You'll know that in the CMS data, because you'll know, well, I think to a certain level, you'll know where the CMS data is coming from and that it's from two different locations. So in some ways, the CMS data kind of bridges that patient among all the sites, but there's still a challenge, I think, with EHR sites that sign the agreement and those that don't, and how you reconcile the patient. So you need to be aware of that. Another thing
Tom,
is with, yeah.
Tom, we will
Yeah, go ahead,
provide
Stephanie.
those duplicated linkage files. So for instance, if there was an EHR record in University of Maryland regarding Stephanie's visit, and she has a different ID, and then let's say she also went to Johns Hopkins, and the Hopkins EHR has a different ID associated with Stephanie, those duplicated person information will be provided to the analysts so that they could check for those duplicated person existing in two different EHR systems.
That's great. Yeah, and thanks. And that helps. And like I was saying, you'll know things that I may talk about here, others, they may be fixed already. So this is a good example of where it may not be totally fixed, but at least there's something that helps you identify as a researcher, who's involved with this, and help me, Stephanie, with the other things too, because the date one that I'll get into now may have been resolved as well. So the other thing is with date adjustments, and been sort of asked, but it was too late to change the slide, not to really talk about date shifting or not call it date shifting. So I'm just going to call it an adjustment. I'm not sure, I couldn't take shift off of the slide everywhere. So just think of it as adjustment instead of shift. I think, but correct me if I'm wrong, there's some sort of adjustment that takes place when the EHRs submit data to the dates to help, obfuscate the dates and protect privacy. And so in this example, I'm just sort of illustrating that a date of November 18th gets adjusted to some other date. In this case, I just picked arbitrarily October 14th. Then another site submits for the same person data, and they have a date shift, and or a date adjustment. That adjustment is different than what's in site A, and so a visit on October 30th gets adjusted to some other date, and I arbitrarily picked the 15th. the CMS data wasn't adjusted. So those two visits, the 30th and the 18th, show up in the CMS data as the 30th and the 18th. So when we put all this together, we're seeing after the adjustments sort of 4 different dates. And maybe this has been corrected, or maybe there's something to help with this, or there will be. But until you know for sure as a researcher, be wary of this and be careful, especially, it might not be a big deal. It's not really a big deal if you're just looking for, did somebody have a disease? Did they have a diagnosis code? But if you're doing things like more strict use of a diagnosis code, like did somebody have more than one, or were they diagnosed with this illness more than once, which we do a lot in research, or we look at utilization, how many visits does somebody have? Be careful that you don't overcount, that we don't count this as 4 different visits or 4 different times that the person was diagnosed with something when it was really just those 2. So that's really all I wanted to say about that. Let me pause though, since maybe Sean or Stephanie or somebody knows that this isn't so much to be concerned about right now, or that there's some fix that I don't understand, or something that I said that's incorrect. Otherwise, I'll just keep going.
I think the primary thing to know is that the CMS data are only available alongside our level 3 LDS data. Most sites do not do any date shifting to protect patient privacy, but some sites do prior to sending it along to N3C. So there's a couple of different kinds of data adjustments in play here. One is date shifting that's applied to the EHR data by some data partners. And then there's potential date discrepancies in the CMS data compared to the dates in the EHR data, just as a consequence of how things are entered in CMS versus EHR. And I don't think we have very many sites that are linking, possibly none, that are linking against the CMS data right now. So this might not be even an issue at this moment, except for discrepancies in CMS.
There are about 10 sites where they shift dates before they submit to N3C. And there is a letter out to all those sites, making sure that their data trust is okay with us, linking with their sites, because we would be able to discover how many dates they shifted for those data that exists in the claims. And so as a result of that, either it's possible that the sites will come back and say, okay, we will submit the data unshifted, or they will either say it's okay that we can discover the dates shifting number for those patients within their site. So their data trust has to approve that it's okay, and we're just waiting for them to respond back to us. And then what Sean had mentioned about the claims data, it is possible for claims information to be not yet recorded because patient has not been discharged during those months, but those data will exist in the EHR data. So there may be some data discrepancy because a claim hasn't come in yet, and because a patient hasn't been discharged from the inpatient facility as of yet.
Okay, so thanks. Yeah, that's all helpful. And yeah, I'm gonna come back to dates in a second here. On this example, I sort of showed clean claims where the October 30th date matches up perfectly with what's in site A's EHR, and the 11/18 date matched up with what's in site A's EHR. but in reality, that's not the case. We find discrepancies. Let me come back to that in a minute. The other thing that I wanted to mention to be careful of, or I would be careful of in using this data, is beginning to link claims to EHR and some of the challenges there. One has to do with whether the sites sign the agreement or not. And I think, there was just some discussion on that and involving date shifting and whether we're allowed to link the CMS claims with the EHR data or not. So that's something to be aware of. And then the second part is the piece I wanted to come back to, and that's just discrepancies. So we see it all the time, and I know a little about why it might happen, but some of it is just errors, and some of it has to do with billing. Like the EHR may put the visit in as the 18th, but there was something happening with the patient, the next day for some reason. So the bill actually goes out on the 19th. So the claim is going to say the 19th, and you look at the EHR and the visit's on the 18th. That happens. It's not like, doesn't happen with everything, but there's, some percentage, less than 10%, but it's difficult sometimes to match exactly a person and a date from a claim to that person and that date in the EHR. So we have to do other things. We have to bring in other information, like look at the procedure and the provider, and then maybe, and then also allow for a window around the date. So, you might look for a claim on the 19th, but allow a 3-day window, look for something in the EHR with the same procedure, from the 17th to the 21st or something like that. So there are different ways to do it, but, when trying to match the EHR and the claims, just be aware that you won't always get an exact matching. You sometimes have to do sort of a relaxed, fuzzy matching to get things to work.
Right. And also wanted to mention the fact that certain claims are filed at a monthly interval. So there may be a claims data up to the last day of the previous month, but the partial month from the next cycle may not be present in the claims as of yet because the patient has not been discharged or it hasn't been a 30-day window as of yet. So there may be some differences based on that. So you may have an EHR data, but the 30-day window claims data may not be present.
Yeah, and that's particularly a case for certain types of claims that we do have, like hospice, home health, skilled nursing facility, where people are in their facilities for a long time. So the hospice or the skilled nursing facility doesn't want to wait until the end to submit their bill. So they'll submit interim bills, on sometimes a weekly basis or every other week or monthly. And so you'll see, as Stephanie said, you'll see, a claim come through. There'll be a bunch of claims that are like from the 1st of the month to the 30th or the last day of the month, and then the next month you might see a claim that's from the 1st to the 8th because then the person got discharged on the 8th. So yeah, there are challenges like that that you need to be aware of. And again, I think over time, my short experience here with N3C, I've only been involved with N3C on the operational side for a couple months, but there are groups I know that, and they're, that build templates and, the whole culture really sort of shares stuff. So over time, templates and different definitions will be put in place that make this easier. But if you're jumping in right now at the start, just be aware of this. That's kind of the types of things that I'm trying to point out now. A year from now, none of this may be an issue. Another one I mentioned earlier, this idea of macro visits. And again, I'll talk about this in general when I deal with claims data, not necessarily an N3C environment. there may be a claim. This is, again, all for the same person, a claim that has a starting date and ending date of the 1st to the 15th. And then another claim that's from the 11th to the 18th. So there's a bit of an overlap there. And then a third claim that's from the 20th of the previous month to the 20th of this month. So all three of these claims sort of overlap in some way with each other. And then even a fourth claim that isn't really an overlap, but occurs on the last day of the first claim, or the maximum date of the first claim, if I put those three together. And so if I want to take all these, say these are all inpatient claims, you know, they're not, or at least the first three aren't three different inpatient stays. There's some kind of overlap, and they're probably bills that are coming maybe from different units within a hospital. I don't know, you know, an anesthesia versus surgery versus internal medicine or something like that. And then that fourth one could be a totally different claim, an inpatient stay or not. So I might put all these together and say this is one big long inpatient stay from the 20th of December to the 23rd of January, based on the earliest admission date, which was December 20th, and the latest discharge date, which was January 23rd. Or it would also maybe be valid for me to say that it's two different inpatient stays. I'm gonna allow that somebody can be discharged and then readmitted on the same day. And if I allow that, then I might consider this two different inpatient stays. There are other things I would do. Like you can look there's a discharge disposition that might tell you, and other codes on the claims like DRG codes, something called a DRG code, diagnosis related group code, which is how CMS pays for Medicare, so inpatient. And so if the DRG was different on these two, then I'd probably consider it two different inpatient stays. If it's the same, I'd probably consider it one. But anyway, it's something to be aware of just with claims in general. And I think a lot of this has been cleaned up to some extent with what Stephanie talked about earlier in the transformation and the definition of visits. But still, since this data is so new, something to watch out for is this type of overlap.
Yeah, so we
and I
did
mentioned
build,
yeah.
so regarding
Go ahead,
macro visit, we did build a macro visit for our EHR data, but we have not done that for our CMS data, and we hope to build that out for analysts to use it as well.
Right, and there are, I mentioned, there are some of the fields that are on claims that you don't see in the EHR really, you may never have heard of. There's something called the type of bill, which is a combination of three different fields. It tells you a lot of information, and it'll tell you, you know, where the bill is coming from at a high level. Like, is it from a doctor's office or from a facility? And it'll also tell you where in a sequence it might be. So some of the examples we gave earlier, where you might see a bill from the 1st to the 30th, and then the 1st to the 8th of the next month. That first bill, some digit in this 3-digit type of bill code tells you that it's not the final bill. And then the 1st to the 8th, there'll be a different digit. So there's a field called type of bill that helps with it. And then Stephanie mentioned revenue codes before. You may or may not have heard of those. They're kind of on claims, and particularly CMS claims. It sort of breaks up the services that a person has into, different service categories, I guess. Sometimes they're like departments. So you might see a revenue code for ER services, a revenue code for anesthesiology, revenue code for durable medical equipment. So there is one for room and board. And so a lot of times we use that. We look for that revenue code, which is, I think the 111 is actually the room and board code that indicates admission through discharge. So, that's the type of bill code. There's a revenue code that goes with that indicates this is admit through discharge, and the revenue code is for room and board. So you want to put those two together, you get an admission date and a discharge date and some other things that tell you that that's what the inpatient stay was. So again, there are some fields on the claim, and if you can look at the links I gave earlier for CMS to the CMS research support site, ResDec, that will tell you about all the different fields on a Medicare claim. And then I talked about the enrollment data earlier in the master beneficiary summary file and how powerful and important that could be. It tells you, all the things I mentioned earlier. In a research environment, identifying continuously enrolled people. Sometimes or usually we'll give you a cleaner cohort to work with. So in cohort definition, it's very useful. You can look at lengths of enrollment, 6 months, 12 months, 1 month, annualization I mentioned earlier, and then the distinguishing non-users from healthy people. You can do that a little bit more with claims than you can in EHR. And then finally, pharmacy. So we have pharmacy. I talked earlier about the fact that the claims are what was actually done, in particular with pharmacy. And the claims have national standards on them. I think OMUP does this anyway, but transforms the EHR data. I don't know how it does it with pharmacy, but there is a national drug code, NDC, which tells you a lot about what the person had filled at the pharmacy, including quantity and day supply. And you can put all of this information together on a claim to do some pretty powerful stuff. Like you can begin to do some dosing, which that part may be a little bit easier in the EHR, but you can also look for prescriptions over time and refill patterns and spikes in medication, particularly in mental health conditions. A lot of times you can identify spikes in different places that are important for opioid drugs, possession ratio and things like that, something called morphine milligram equivalents. We can do all that with claims. So it's powerful stuff, and having the claims, pharmacy claims, makes it a lot easier to do this. It's difficult and you have to make a lot of assumptions with EHR data to be able to do some of this stuff. So I think that's it. Again, if it's important from reimbursement, certainly pharmacy is, then you can trust the pharmacy data and diagnosis codes and procedure codes and provider and place of service, dates of service. You can kind of trust all that from the claims. So I think that's it. That's all I have. So Sean, I'm going to stop sharing again.
Thank you, Tom. So what I will talk about now is how to actually get access to this data. So the CMS data is part of the privacy preserving record linkage effort in N3C, and this is really what allows us or enables us to link together data about an individual patient without actually anyone knowing the personal identification details like name and birth date of that patient. So it's a pretty cool process that involves some neat encryption. PPRL data is only available alongside what we call a limited data set or level 3 DUR. And so when you submit the request to access some data, you'll have the chance to request the level 3 data. And if you select that, you'll then have the chance to select the CMS data. When you're doing that, the level 3 data requires that you have a letter of determination from your local IRB. And that letter of determination should also mention that you're accessing the CMS data too. So the IRB should be aware of all the different kinds of data that you'll be accessing as part of the project. And when you submit that DUR, the committee that reviews it will be looking for that as well. For a little bit more information on PPRL in general, we covered this back in March as part of the community forum. And here's the link there. Again, we'll share these slides, or at least this recording. And we also have some how-to docs and some guides around PPRL in general, including the CMS data, which is still a little bit of a work in progress, but we got most of the information there. You can find out about our training portal, which lives inside of the Enclave here at covid.cd2h.org/training. And that's probably also in the PPRL training module. That's probably where we'll be linking to this presentation and recording, maybe other venues as well. But if nothing else, you should be able to find it in the training portal under the PPRL training module and then in the CMS guide document. We already briefly covered this, and I know that we're at the top of the hour, so if folks have to leave, I think you won't be missing anything too serious, but I wanted to talk a little bit about how patients are linked to different sites and CMS data. So, for example, if you're familiar with N3C, you know that we sort of have person IDs that visit a site, and we might have another person that visits a site. And so these two individuals get different identifications. This site here may have agreed to linkage with the CMS data, but this site did not. And so in the CMS data, you'll see, like in the condition occurrence table, that there's a CMS person ID. So all of the CMS data gets its own unique person ID, and the data partner ID is going to be listed as CMS. And then there's a mapping table that tells you which CMS patient maps to which N3C patient. And this would tell me, for example, that CMS, this person maps to 111 here, but we of course don't see 22222 in the mapping table because this has not agreed to that mapping. But things can get interesting with CMS because when we get data about a given patient for CMS, we get information about all of the different places that they went for care that was submitted to CMS claims. And what that means is if you have a situation like this, where we have person ID 33333 and another one 44444 at two different CMS sites, it could well be that these are both the same CMS person. And this basically indicates that 33333 and 44444 have different names according to our different sites, but they're actually representing the same individual that visited multiple sites. That's pretty rare in the data, but it is possible, and it is there for a few patients. And so I'm sort of indicating that here by putting, a bow in our hair. We might also have a situation like this, where suppose, for example, we wouldn't know this, but suppose we would know that these two patients happen to be the same person that visited two different sites. But one of them linked to the CMS data and one of them did not link to the CMS data. What that would look like is we would only have the mapping for the person ID and the N3C person ID where the site has agreed to that mapping. But we would have all of the data for this person regardless of where it came from. So this record could actually have been happened at this data partner, and this record could have happened at this data partner, but you don't have an easy way to know that because this data partner has not agreed to linking the CMS IDs to their person IDs, if that makes sense. And as a reminder, as part of the data use requests and the data use agreement, you are agreeing not to attempt to re-identify patients or data partners. So, and as a wrap up, we do have office hours Tuesdays and Thursdays, and Thursdays are when Tom is around to answer questions generally. We have a PPRL training module in the training portal, and we will be putting this recording up on YouTube and linking to it in that training module that I mentioned. And I believe that is all for now. Any last questions for the Q&A? Wei asks in the question, is it possible for one patient to have multiple N3C person IDs? Yes, it is. So we do not currently have it set up so that if a single patient visits two different patient IDs in the if a single patient visits two different data partners in the EHR data, they will get two different N3C person IDs. You would be able to distinguish that if you had access to the N3C, the CMS data, and they happen to be linked to some CMS data. Well, thank you all for coming. If we have no last minute question, oh, here's one last minute. Oh, thanks for today's presentation. You are very welcome. Thank you all for coming, and we hope you have a wonderful day. Shruti, I think we can probably stop the recording.